Welcome, everyone, and thank you for joining us. My name is TenYear Long, and I'm Senior Manager, National Education for Osteoporosis Canada. I am very pleased to be your moderator today. Each Bone Matters Take Charge of Your Bone Health presentation is led by a Canadian expert in osteoporosis to help participants better understand how to prevent the next fracture and how to live well with osteoporosis. Bone Matters is an ongoing series of live and archived presentations. And today we are delighted to welcome our guest speaker, Dr. Bill Leslie. Fractures or broken bones are the most significant consequence of having osteoporosis. In the past few years, therefore, the emphasis has shifted from bone mineral density test results to a comprehensive fracture risk assessment as the basis for diagnosis and management of osteoporosis. Dr. Leslie will address such questions as what is a fracture risk assessment and how does it improve patient care. To submit a question, on the side panel on the right side of your screen, you will see a box that says Questions. Type in your question in the text box and we will receive your question to ask at the end of the presentation. You may submit a question at any time during the presentation, and it will be addressed during the Q&A period if time permits. If not, we will answer after the presentation, so please be sure to include your email address in the body of your email. Otherwise, we will be unable to send the answer. Dr. Bill Leslie is a member of the Scientific Advisory Council, Osteoporosis Canada. He is a professor in the Department of Medicine and the academic head, Nuclear Medicine, in the Department of Radiology, University of Manitoba. His research interests include fracture risk assessment, osteoporosis testing, and other nuclear diagnostic techniques. He is the director of the Manitoba Bone Density Program. He has over 300 peer-reviewed publications, sits on the editorial board of a number of medical journals, and is the associate editor of the Journal of Bone and Mineral Research. We are very pleased to welcome you, Dr. Leslie.
Well, thank you very much. It's my great pleasure to be able to speak to this group today and to share one of my passions, which is in the area of fracture risk assessment, which is the critical component of osteoporosis care. And this has evolved considerably over the last few years. And over the next 30-35 minutes, I will share some of that with you. I'm hoping that you can see my screen now.
Yep, all good, Dr. Leslie.
Okay, good. Thanks for that confirmation. So I'll be presenting from the City of Lights in Winnipeg, as you can see. And my intent over the next while is to review fracture risk assessment, how and why that's changed over the last decade and a bit, and to share with you how there have been recent advances since the 2010 guidelines in fracture risk assessment, and how we can harness those to improve patient care. These are statistics that are sobering and are familiar to all of you on the call. The number of low trauma, osteoporotic fracture, fragility fracture, we use the term somewhat interchangeably, and I'll share a bit of a definition in a moment, is staggering. These are Canadian statistics, and you can see that the annual number of fractures, if you total up hip, spine or vertebral, the forearm or wrist fractures, pelvic fractures, other fractures, dwarfs the total number of heart attack, stroke, and new cases of breast cancer that occur in the country. So this is a very large problem and has very large health consequences for Canadians. What is a fragility fracture? This comes up frequently, and I think people sometimes get a bit too preoccupied with it. Essentially, it's a fracture that occurs during average activities, daily wear and tear type activities. We just define that more technically as a fracture that occurs either without any injury or with a very routine or minor injury, such as fall from standing height or less. Now that means that if you fall slipping on the ice, that's fall from standing height. If you trip on something, that's fall from standing height. What we're trying to do is to simply distinguish those fractures that are routine daily type events from those that are clearly outside of the range of normal injuries, such as falling off of a ladder, falling out of a tree, falling off the roof when you're cleaning the snow from your roof. Usually, it's quite obvious the difference between those, and sometimes there is a bit of a gray zone. But I tend to be fairly permissive, and anything that is not a major trauma, I consider as a fragility fracture. Now, typically, we exclude the head and neck because these are sites that are almost always related to very severe trauma, fisticuffs and the like. Hands, feet, ankles as well have not been associated with osteoporosis, and so we exclude ankle fractures, although they are very common. We'll revisit this question of what is a fragility fracture a little later. What's more important is the consequences of fracture, and the consequences are huge. Fractures increase risk for hospitalization, long-term care in nursing home, the increased risk of death, as I'll share with you in a moment. Of course, once you've sustained one fracture, you're typically at very high risk for more fractures, and the risk is even higher in the early period, the first couple of years after a fracture. Fractures are painful. The impact on quality of life in the short term, and for some individuals in the long term. And of course, they are expensive. They cost upwards of $30,000 to $40,000 for care of a hip fracture, and very expensive for other fractures. So these impose an enormous economic burden to the Canadian healthcare system. This looks at the death consequences of a fracture. And these are data that Suzanne Morin has published, and it's based upon the entire population of Manitoba, but I can assure you Manitobans are no different than other Canadians. And this looks at the relative risk for death, where one is average, for women or men following a fracture. And this isn't the first year. And this looks at hip fractures in the blue, spine fractures in a darker blue, humerus or upper arm shoulder fractures, wrist fractures, or other types of fractures. And you can see that even when you consider age, person's sickness level, their comorbidity, whether they were living at home or whether they were getting health care from home care services or were in a nursing home, if you consider their level of health at baseline, even considering that, a fracture increases risk for death by about twofold for women and about threefold for men. So although men fracture less often than women, when they do, they suffer more severe consequences and are at higher risk for death. The only fracture so far that does not appear to have a long-term mortality effect is wrist fractures in women. But wrist fractures in men, again, highlight an individual who's at higher risk for death. So preventing that fracture is not only beneficial to prevent another fracture, but also to reduce risk of death. These are sobering statistics that are familiar with the group on the call. Unfortunately, osteoporotic fractures get no respect. We're like the Rodney Dangerfield of healthcare. If a person has a heart attack, discharge from hospital without any care to prevent another heart attack would be considered criminal. And so a common medication that's used, a beta blocker, is prescribed in about 80% of individuals discharged from hospital after a heart attack. And usually they're taking this plus a lot more to prevent the next heart attack. In contrast, after hospitalization for an osteoporotic fracture, the percent of people that are discharged from hospital on preventive care to prevent the next fracture is very low, less than 20%. There's more gap than care in the current situation. And this, unfortunately, has not improved over time. These are data that Suzanne Morin presented about a year ago. These are national data that look at the percent of individuals who receive osteoporosis medication use, so appropriate secondary prevention 1 year after a major fracture in Canada, and looks at how this has changed from 2000 up to 2015. Women are in red, men are in blue, and you can see that from about 2000 up to about 2008, 2009, there was an improvement. It was never great. You can see that we got from 20% up to about just over 25%. So again, still more gap than care, but at least there was improvement. But we've been losing ground over the last few years. You can see that starting around 2009, rates have actually declined back down towards that 20% level in women, and again, well below 20% in men. Why has there been a drop-off in post-fracture care? Well, it's the concern with safety of medications. Now, all medications have side effects and have to be used judiciously to make sure that we get benefit in the appropriate population and avoid side effects or complications in individuals that are not going to benefit from medication. But the approved medications for osteoporosis care, especially in individuals who have already sustained a fracture, the highest risk group, are clearly going to have more benefit than risk. Unfortunately, headlines like this from the New York Times that highlight the risk of rare side effects with long-term use has left people nervous about taking what are really very safe, very effective medications. To put it in context, this looks at the risk of fracture and other rare events per 100,000 years. Now, not many of us on the call are going to be alive for 100,000 years, but imagine that you had 100,000 people you were following for 1 year. And this looked at the likelihood of some of the complications that have been associated, in some cases not even proven to be associated with bisphosphonates, which are the most commonly used osteoporosis medication. You can see that for osteonecrosis of the jaw, that's the complication that affects healing of the jawbone, that the rate is about 1 per 100,000 person years. For atypical femur fractures, those thigh bone fractures that have been associated with long-term bisphosphonate use, it's maybe 2 per 100,000 after 2 years and increases, but is still only 78 per 100,000. That's less than 1 per 1,000 after 8 years of use. You can see in context, death by murder, fatal motor vehicle accidents are really on the same level and are much more common than some of these rare drug-related side effects. Now, if we look at the potential benefit from treatment, these are low risk, medium risk, and high risk women. And you can see that in a high risk woman whose rate of fracture is over 3,000 per 100,000 years, if we could prevent even a small fraction of this, let's say that we have a medication that could prevent about a third of those, we would be preventing about 1,000 fractures per year in this 1,000 fractures per 100,000 years, which would clearly be much more beneficial than all of these risks if you were to sum them up together. So by targeting high-risk individuals and using effective treatments, the benefit of treatment clearly is going to be much greater than the small risk of harm. This brings us to the Osteoporosis Canada Patient Bill of Rights. Canada is a leader in promoting patient access to osteoporosis care. I won't read this out to you, you're familiar with this, but it does underline that all Canadians, wherever they live, have a right to effective bone care and fracture prevention programs. So now we'll launch into the guidelines from 2010 and then what advances have occurred since then. The two main changes that occurred in the 2010 guidelines compared with the previous 2002 guidelines were an increased focus on the importance of fragility fractures, Simultaneously, a de-emphasis on the importance of bone density looked at in isolation, so bone density is now part of a more comprehensive assessment, and an increased focus on the care gap that exists post-fracture, and recognizing that the highest risk individuals who've already sustained fractures are not being adequately treated. This is the reason that we're moving away from bone density alone as a tool for deciding who should be treated and who should not be treated. This looks at the rate of fractures per 1,000 person years according to bone density T-scores and according to whether the bone density is in the normal, osteopenia, or osteoporosis range. And not unexpectedly, as the bone density T-score gets lower as you go from normal or even greater than 0 down to very low levels in the osteoporotic range, less than minus 3.5, which are very low T-scores, you can see that the rate of fracture increases progressively. However, most people in the population do not have very low bone density measurements. Most of the population, the older female population, actually is in the osteopenic range. And so the bars represent the numbers of fractures, not the rates, but the numbers of fractures. And you can see that the numbers of fractures tend to peak at a T-score in the range of minus 1.5 to minus 2.5, so actually in the osteopenia range. What that tells us is that approaches that are focused only on those with an osteoporotic T-score will miss the boat for where most of the fractures are actually occurring, which is in the osteopenic range. So we need better tools than bone density. Bone density is good, but it's not good enough. This is another sobering statistic showing that when we looked at treatment rates for individuals according to whether they qualified for treatment under the Osteoporosis Canada guidelines, so these were all high-risk individuals under the Osteoporosis Canada guidelines, and we looked at the numbers of people that were being treated, even though they were high risk, they had a hip fracture, a vertebral fracture, high FRAC score, whatever it was, that the only thing that seemed to affect the patient and doctor decision to initiate treatment was whether or not bone density was normal, osteopenic, or osteoporotic. Unfortunately, we've done such a good job in explaining the importance of a BMD T-score that people are still not aware that high-risk fractures need to be treated. And so even if your bone density is normal or osteopenic, it doesn't matter. If you've sustained a high-risk fracture, you should be treated, but currently that is not happening. This looks at the Osteoporosis Canada guidelines, and after that initial fracture risk assessment, we are trying to target those that are high risk. That means a 10-year fracture risk of greater than 20%, or people who have already sustained a typical osteoporotic type fracture that affects the hip, the spine or vertebra, or who have had more than one fracture episode, say affecting one wrist 1 year and another wrist the next year. These are high-risk individuals. This is where we have the best evidence for treatment from medication, and where we should be really devoting our effort. Now, how do we do that 10-year fracture risk assessment? We can use one of two widely available simple tools that have been well evaluated in the Canadian population. One is the so-called FRAX tool, which comes from the University of Sheffield, and I'll share that with you in a moment. The other is the CAROC tool, which is very similar, was developed with the Canadian Association of Radiologists and Osteoporosis Canada. It looks different on the surface, but in fact, under the hood, it is very similar to FRAX. So we'll start with the CAROC tool, which was first developed in Canada back in 2005. It's a risk assessment system that is designed to report risk not as a percent risk, but as a category of risk. So it's low, moderate, or high, where low typically is less than a 10% risk of fracture over 10 years, moderate is 10 to 20, and high is greater than 20%. And when we talk about a major osteoporotic fracture, we're talking about fractures of the hip, the spine, the forearm, or the shoulder. So those four are the typical major osteoporotic fractures, although there are other important fractures that can be caused by osteoporosis, such as the pelvis. This is how the FRAX group defines the major osteoporotic fractures, and by extension, how the CAROC tool uses the term. Now we have three broad zones, and I'll show you how these are used in a moment. And we consider two additional risk factors: the presence or absence of a fragility fracture after age 40. Nothing magic about age 40. It could be 41, 45. It's just to make sure we're not counting fractures from childhood or adolescence or sports-related injuries that are quite remote. And a single medication, the steroids or the glucocorticoids, which are used to treat typically inflammatory problems, and where prolonged high dose has been strongly associated with fragility fractures, especially spine fractures. And we consider prolonged use as use in the last year of greater than 3 months at a high dose of more than 7.5 milligrams per day. To show you how this works in practice, consider a 65-year-old woman who has a hip T-score of minus 2.8, so in the osteoporotic range. If we were to just use that piece of information, her age and her T-score, and apply it to the CAROC lookup graph here, you would see that even though she's osteoporotic, she's not considered high risk. She's actually in the moderate risk category. This is where she plots out. However, if she had additional risk factors, such as a previous fracture or the steroid use, then we bump up her risk by 1 category. So she shifts up a category from moderate to high risk in this situation. So this is practically how the CAROC tool is used. There are different tools for women and men. Women are not the same as men when it comes to fracture risk, and there are very different looks to these. So if you use doing a risk assessment in a man, you need to use the FRAX tool for men, or the CAROC tool for men. Now, the FRAX tool has been available for Canada since July of 2010. If you go to the FRAX website, and it's a web calculator, but it also has smartphone applications, you'll see that there are over 60 calculation tools that can be used. So these are customized to every different country and population. The Canadian tool took some time to develop and was developed and confirmed for use in Canada in 2010. The pieces of information that went into creating that Canadian FRAX tool were national hip fracture data for 2005, national mortality data for 2004. We had to estimate other types of fractures from the hip fracture rates and then validate these predictions in over 45,000 Canadians. So the Canadian FRAX tool has been more closely scrutinized than any other FRAX tool on the planet, in my opinion. Why is it important to have a Canadian FRAX tool? Well, if you actually look at the output from the calculator of FRAX and use exactly the same inputs, age 65 with a previous fracture and a hip T-score of minus 2.5, so at the osteoporotic threshold, and simply change the calculator from Sweden to Switzerland to US Caucasian all the way down to Turkey, you can see you get a different output. So same inputs, different outputs. And so the Canadian tool is best reflective of fracture risk for Canadians. And you can see that we're actually in the highest risk population, higher risk for the world, with rates that are similar to the United Kingdom, but considerably greater than many other countries. I don't have all of the FRAX tools, but this just gives you a taste of the range that you can see around the planet. This is the information that needs to be entered into the FRAX tool. You need to enter age, sex, height, weight, a few yes/no questions about previous fracture, parental hip fracture, current smoking, the glucocorticoids use, rheumatoid arthritis, secondary osteoporosis, high alcohol use, so 3 or more drinks per day essentially, and the hip bone density measurement either as a T-score or as the direct output from the calculator. One of the nice things about the FRAX tool, unlike KROC, is that if you don't know bone density, you can still use the FRAX calculator, and it will use height and weight as a way to sort of estimate what the T-score would be and give you still a reliable fracture risk assessment, although you get a better result if you actually have a bone density measurement. So if you are going to use this, it's important to remember that if you're entering a T-score, it's supposed to be, assumes women age 20 to 29, so we use the same T-score methods for men and women. In fact, this is now standard practice in the Canadian guidelines, and it's standard practice in the KROC tool as well to use the same level playing field for measuring T-scores in men and women. So if we go back to that first case I shared with you about the 65-year-old woman with a T-score of minus 2.8, if she has no additional risk factors and we punch in the FRAX calculator, we get a 13% major osteoporotic fracture risk. So in the moderate range, which is exactly what the KROC tool gave us. If she had additional risk factors, if we put in fragility fracture or glucocorticoid and recalculated this, her fracture risk would go to 21%, so she would be in the high risk range, again, the same as the KROC tool. When we compared the FRAX tool and the KROC tool in over 35,000 Canadians, we saw that basically both tools work very well. Low, moderate, high. If you look at the actual fractures observed in the population, they go up as you go from low to moderate to high, both with the FRAX tool and with the KROC tool. So they both deliver what they claim in terms of the risk assessment. They give exactly the same risk category most of the time, 90% of the time. So I consider them two different flavors. There's the full-bodied FRAX tool, and then there's FRAX Lite, which we call the KROC tool, which is more similar than different to the FRAX tool. What's more important is to be aware that we have effective treatments for osteoporosis. These are the approved medications, and the ones with a green tick box indicates they're effective for treating the specific fracture type. And so if you're looking for protection against vertebral, hip, and non-vertebral fractures, you can see the bisphosphonates and denosumab and estrogen therapy, although a second-line therapy, are all effective for those. This looks at the importance of the time since the previous fracture. And so if you look at years from the previous fracture, from 0 out to 15, you can see that the relative rate of fracture compared with 1, which is baseline, the risk of fracture stays up forever. So even though you had a fracture 15 years ago and haven't had a fracture for 15 years, it doesn't mean your fracture risk has gone back to baseline. You're still at increased fracture risk, both men and women. However, if you go backwards, you'll see here that shortly after that fracture, you're at much higher risk. So women and especially men can be at 2- or 3-fold increased risk for the first few years after a fracture, and then that gradually declines over time, but never back to baseline. Vertebral fractures are particularly important in this scenario, and you can see that spine fractures, vertebral fractures, automatically qualify you as high risk. For those that are at moderate risk, we're recommending spine imaging to identify vertebral fractures, because once you identify a vertebral fracture either off X-ray or so-called vertebral fracture assessment, which can be done with bone density measurements, then that automatically identifies you as high risk because you've got a vertebral fracture, and of course that's where we have our best evidence for treatment. This is what a vertebral fracture assessment looks like. On the right is a normal spine, no fracture. On the left, pretty obvious, severe fracture, which may not have been diagnosed before because so many of these do not produce severe pain. But once you identify it, this person is now high risk for future fractures and should be on treatment. Do they get treatment? Well, since we started using vertebral fracture assessment in Manitoba, we've been able to look at that, and we have shown that when we identify a positive vertebral fracture assessment, a positive VFA, this dramatically increases the likelihood of people initiating treatment. So this is treatment initiation. Low fracture risk, without a vertebral fracture, very low rates of starting treatment. With low risk, but with a vertebral fracture, you increase your chances of being appropriately treated by about 25%. Large effect for moderate risk when you find a vertebral fracture, and a smaller effect when you're already high risk, because many of these people would be treated for the high risk already. So vertebral fracture assessment is beneficial for treatment initiation. Now, if we had a 70-year-old woman with this story, breast cancer starting aromatase inhibitor therapy, which is bad for bones, she's osteopenic at baseline or has low bone mass and has a FRAC score of 31%, I think if I was to ask for a show of hands, most people would say, based upon the Canadian guidelines, she should be treated. This is a real case. She came back to us 2 years later, not receiving treatment, but still on the aromatase inhibitor therapy, still osteopenic, and now her FRAC score was 7%. And so the correct answer to what's going on is on this slide. Something doesn't make sense. You don't go from 30% to 7% without treatment. And this is what happened. It's when she came back and we filled in all of the FRAC's questions, all of the answers to the questions came back as no. But when we went back to her previous visit 2 years earlier, she said, I had a prior fracture, I fell on the ice, I injured my wrist, but I didn't go to see anybody, so I didn't get an x-ray. I just thought maybe it was broken. The parental hip fracture, yes, that was real, but she was adopted, so it wasn't really a true familial association. The use of glucocorticoids, which she previously identified, was only very brief and used with her breast chemotherapy, so only a few days at a time. And the rheumatoid arthritis has now been re-diagnosed as fibromyalgia. The important point of this is that if you're going to use a calculator with questions, the inputs have to be correctly identified, because garbage in, garbage out when it comes to any kind of a risk assessment tool. This is another real-life case, a 79-year-old woman. She had a left wrist fracture at age 55, fell while curling, another one when she stepped off a curb. She's had long-term diabetes for now almost 30 years, type 2 diabetes, and her father had a hip fracture at age 102. Which of these do we include in the risk assessment? Well, if we do the FRAC's calculation without bone density, which we can do, if you have no risk factors, her risk is 17%. That's just based upon her age. So she's moderate risk based upon age. If we include prior fracture, she goes up to 28%. Prior fracture and parental hip fracture up to 44%. And if we include prior fracture and rheumatoid arthritis, which we can actually use as a substitute for long-term diabetes, we've shown this works, her risk is 38%. So it's very easy for this woman to go from moderate up into the high-risk category, greater than 20%. Now, personally, the fact that her father broke his hip at age 102, good on him. She's got good genes in terms of longevity, but we've shown that fractures after age 80, hip fractures probably don't mean as much as fractures occurring in parents when they're much younger. We're still not sure whether fractures during curling should be fragility fractures, or is that a sports-related injury? Now that curling is in the Olympics, I guess maybe it's a sports injury, but we would definitely count the second one, stepping off a curb. I don't consider that a fall from height. Curbs are not a significant elevation, and we can use the type 2 diabetes using the FRAC's input to get her to using the rheumatoid index up to 38%. So if we were to do that with the bone density T-score, it doesn't make a big difference. She's still at high risk if we include the previous fracture and the rheumatoid arthritis information. If we were to use the CAROC tool, it only allows us to count one fracture. So we again count that stepping off a curb and injuring your wrist. We can't count diabetes. It doesn't have a place for hip fracture in the parent. And so the CAROC tool with a hip T-score of -2.2 would be moderate risk. But if we add in the prior fracture, then that bumps up from the moderate risk up to the high risk. So again, we get to the same result. All roads lead to Rome. When in doubt, our practice is to look at the spine. If you identify a vertebral fracture that was not previously known, that makes decision-making very easy because now this person is automatically high risk and deserves treatment. It's important to look at all the spine imaging because then sometimes we find that these are X-rays or CTs where the fracture has actually been present for several years and has been missed. So we're doing our best to now educate radiologists and other healthcare professionals to improve their ability to diagnose vertebral fractures and report those so that they can be acted upon. So quickly, in summary, FRAX is a quantitative tool. The CAROC tool that I've shown you is a semi-quantitative tool. It gives you risk categories, not a percent output. CAROC is simpler, and it has a simple table or a graphical use way to implement it. FRAX requires more data collection, but as a result, it's more quantitative and more accurate, and it is inherently computer-based. Importantly, they're both widely available. In 2010, CAROC was widely used because FRAX was just new on the market. Now FRAX is more widely used. Neither of them includes falls. Neither of them includes every risk factor known to man because there is just too many to do, and both need to be used with appropriate clinical judgment. So these are the concluding thoughts. Hopefully I've convinced you that osteoporosis fracture risk assessment and care is much more than a bone density measurement or a T-score, and that we now have good tools that improve our ability to identify high-risk individuals and to improve post-fracture care. Thank you for your attention.
Okay, thank you. And let's move right into the question and answer portion. Let's begin, and you're going to have a different voice coming on right now to ask the questions.
Okay. Hi, Dr. Leslie. So I'm just going to read the question out to you. This question says, what kind of emphasis is put on prevention and natural remedies versus medication?
The 2010 guidelines put a lot of emphasis on non-pharmacological approaches to prevention of fractures. We're not all about solely medication. We know that exercise, diet, healthy lifestyle, avoidance of smoking are all critical components of skeletal health and prevention. And in fact, all of the medications have been shown to work when used in conjunction with those. So the basic components of bone health are important both for prevention and for treatment purposes. Medication definitely has a use, not for everybody, not for low-risk individuals, for high risk in conjunction with all of those other components. Falls assessment, falls prevention is also critical because most of the fractures that occur are a result of falls. And so maintenance of balance, physical strength is also an important component of the non-pharmacological prevention of fractures. In the new guidelines, which are being developed, there will be expanded areas on both the exercise component as well as on the nutrition and diet. That is still being worked on, but it will expand on what was in the 2010 guidelines.
Okay, the second question is, how recent should a BMD be for FRAX? There's
no magic cutoff on this. Bone density changes relatively slowly in the average person. The average rates of loss are about 0.5% to 1% per year. So if a bone density is 1 or 2 years previously, most of the time the FRAX score will be very much the same. What has a much larger effect on the risk calculation is actually new risk factors. So if you actually go online and try this out yourself, you'll see that if you change the BMD T-score a little bit, say go from a T-score of -2.2 to -2.4 or -2.5, that will have a very small effect on the risk calculation. But if you either start smoking or quit smoking, or there's a new fracture or a parent that has a hip fracture, that will have an immediate, very large effect. Now, some individuals are at higher risk for more rapid bone loss. Specific medications, the steroids we talked about, the aromatase inhibitors used for breast cancer, androgen deprivation therapy for men with prostate cancer. In that situation, bone density measurements probably need to be obtained more frequently and be more current, preferably within 2 years. But there's nothing wrong with doing a FRAX calculation on a bone density that is a year or two previous.
Do we know why there is such variation in different countries?
We don't. We don't really have much insight into that at all. If you look between the different countries, and there have been many, many studies on this, the rates of fractures, in particular hip fractures, which are the ones that are most accurately measured and counted, differ by more than 10-fold. So that's a huge range between countries. If you actually look at the bone density in those different countries, it doesn't show very much difference. Yes, there are some slight differences between different countries, but not nearly enough to account for that large difference in hip fracture rates. So it's more to do with other components, maybe the predisposition to falls risk, lifestyle. It's tempting to say that this is genetics, but I'm skeptical of that because when we look at changes in fracture rates that occur in different groups, such as in Canada, North America, in Asia, we see that actually the fracture rates have been changing very rapidly in the population, much more quickly than we can explain from genetics. So again, it comes back to something that's probably connected to lifestyle. But beyond that, we really don't have any insights.
Why is race not included as a consideration in the Canadian version of the FRAX tool as is seen in the US tool?
Well, there's several practical issues there. I'll point out that the whole concept of race is one that is hotly debated by anthropologists. There is a school of thought, in fact, the mainstream of anthropologists, that race as a scientific concept is not well supported. Ethnicity as a broader reflection of human diversity, yes, but if you look at ethnic diversity around the world, we don't really have clear definitions. There are thousands, if not tens of thousands, of different ethnic groups. So it becomes increasingly complicated to know if we were to try to create multiple fracture risk tools for Canada, how broad or narrow those would be, and whether we in fact have sufficient data to develop those. Now, the United States and one other country on the planet, in fact, Malaysia, are the only two countries that have incorporated a race/ethnic component to their risk calculators. Other countries, which are just as ethnically diverse as Canada, have not. And I think it certainly makes life a lot simpler when we consider risk based upon a single metric measurement, rather than trying to complicate it with multiple risk calculators for Canada, because in fact We could also develop risk calculators for every province or north-south, and it becomes increasingly complicated, and I'm not sure that there's value in that.
What is the determining factors when deciding if a person should have a spinal X-ray?
So under the current Osteoporosis Canada guidelines, we highlight several situations where spine X-rays or vertebral fracture risk assessment with DEXA, if you have it available, could be considered. One of those is if people have had significant height loss, individuals who have either self-reported height loss exceeding 2 inches or measured height loss exceeding an inch, who are increasingly stooped in their posture, the so-called kyphosis or dowager's hump, or other things that can be detected on physical examination that may be a clue to a non-painful vertebral fracture. So those are parts of the physical assessment, the clinical assessment that we previously highlighted that could be used to identify individuals that might benefit from spine imaging. The other situation, as I showed you, is in the moderate risk category, where we're looking for additional information as to whether or not this moderate risk individual is more like the low risk or more like the high risk group in terms of whether or not they might benefit from more aggressive treatment than simply a lifestyle. So essentially, would they benefit from medication? In that situation, the moderate risk group, we highlight that vertebral fracture assessment or spine imaging may be very helpful, because in that group you have the possibility that you might find a fracture that would automatically make you high risk and eligible for treatment. I guess the question then follows, why don't we do it in everybody? And it's a law of diminishing returns. If we were to do healthy 50-year-olds with a normal bone density, the chance of finding a vertebral fracture is so small, and the chance of that fracture being connected to osteoporosis is also small, because maybe some of those vertebral fractures are actually injuries from when they were adolescents, playing football or involved in other youthful, exuberant activities. So that under the guidelines, we try to highlight where we're likely to identify fractures that would be indicative of osteoporosis and benefit from treatment. There will be more of that in the new guidelines, where we're trying to provide greater guidance on which individuals will benefit from spine imaging.
If a patient has a femoral T-score, is that the one to use in the FRCPC tool? The results page says femoral neck T-score, does not say femoral neck T-score, it just says femoral T-score.
Well, the femur neck T-score is the correct one to use in the FRCPC calculator. It's the correct one to use in the CAROC tool as well. And that's on a routine printout from any of the bone density measurements. They all have a femur neck T-score. Sometimes people abbreviate it and just call it a femur T-score. There is another measurement you can get called the total hip or the total proximal femur, which includes the femur neck, but that's not the one that you preferentially should use. You should preferentially use the femur neck T-score, although in truth, the femur neck and the total proximal femur are very similar.
Due to spinal fusion and hip replacement, a BMD could only be done on the forearm. Will this be accurate?
Well, the forearm measurement will be accurate for the forearm. The question that the person is getting at is, will it be an accurate measurement for the sites that you can't get at, the spine and the hip? And the answer is no, but it's the best you've got. The correlation of one bone density site with another is good, but it's not perfect. So that's why we actually do the spine and hips together, That's why we do the hip, because in fact, if we could get away with just doing one site like the forearm, because it's accessible in almost everybody, nobody few people actually get wrist replacements, and yet a lot of people get hip replacements, then we would use the forearm. But in fact, the hip is the preferred site because it has been most strongly linked with hip fracture risk and with other fractures, and so that's why the FRAX tool is based on the hip measurement. It's the preferred site, but in the absence of a hip or a spine, then you would use the forearm simply because there isn't an alternative.
Okay, and we're going to take 2 more questions. Any tips on how to have a discussion with your radiologist who will not recognize falls on ice as fragility fractures?
Well, this sounds like a question of sensitivity, and I don't know that there's a simple answer on that. There are some publications that have been research that have shown that even high trauma fractures are predictive of future osteoporotic fractures. And so that the distinction between the low trauma fragility and high trauma is somewhat arbitrary, and some would argue maybe even elusive. We've done some research recently on this as well and seen the same thing, that high trauma fractures seem to predict individuals who are at higher risk for osteoporotic fractures. So that's been my experiences, and evolution in this area is to become more inclusive of fractures as fragility fractures and less restrictive. I can provide the references to TenYear. That may be helpful, but I don't have another simple answer for you.
And the final question is there a projected date for the release of the new guidelines?
Yes, soon. But by soon, don't hold me to a date. We've been working on these, but there is much work to be done. These are very complex. The requirements for guidelines development cannot be rushed. There are over 50 people that have been part of this process. It's been ongoing for almost 2 years now. We are into the latter part of the process, but I can't give you an exact release date.
On behalf of Osteoporosis Canada, I thank you, Dr. Leslie, for today's presentation. I'm sure that your expertise will no doubt have answered many of the questions of the participants about the importance of fracture risk assessment for the diagnosis and management of osteoporosis. Let us know what you thought of the presentation by filling out the evaluation survey. You can access the survey via the link that will be sent to you in a post-presentation email or via the Osteoporosis Canada website. So how do you find out about upcoming Bone Matters presentations? Notices will be published on the Osteoporosis Canada website, news and events, and through our social media feeds on Facebook and Twitter. Better yet, sign up for COPAN, the Canadian Osteoporosis Patient Network. All COPAN members are alerted to future Bone Matters presentations. If you're not already a member, sign up for free membership by going to our website at osteoporosis.ca/COPAN. That's COPN. A special thank you to everyone for coming today and for asking all those good questions.